Hi, I'm Dave Fornell, a digital editor with Cardiovascular Business News, and I have with me Michael Mack. He is the chairman of the Cardiovascular Service Line at Baylor Scott White Health, and you've been heavily involved with the partner trials and with TAVR since the very beginning, and here we are in 2022. I wanted to find out where we're at with TAVR and where things are going.
Well, my initial involvement was in the year 2000. I actually saw a TAVR in an animal model in the year 2000, and it was an aha moment. It took a microsecond to connect the dots. This is really going to work. I never would have invented it myself because as a surgeon I knew all the failure modes and why this couldn't work, but once I saw it, I knew, I was pretty sure it was going to be a big deal. I had no idea how big a deal it was going to be. No idea. We thought it was going to be initially a niche procedure for inoperable patients, but we also had no idea how many inoperable patients there were out there because it never came across the surgery radar screen. So despite my early optimism and enthusiasm for it, it far exceeded my expectations.
I remember sitting in sessions, 14 years ago at TCT, and the TAVR sessions were all kind of in the afternoon. They were not very well attended because everybody thought that it wasn't going to be a technology that was going to take off. But when the trials started getting evidence and you had the late-breaking presentations, the numbers seemed to be good from the get-go and just kept getting better.
Well, there's three principles of clinical adoption of any new technology or technique, and that is robust clinical evidence, teachability, and user-friendliness. And TAVR had all of those three. And I think that the evidence base was so strong, especially against a competitive standard of care with surgery, that it's hard to argue with the data. And I give the FDA credit for holding the bar high in terms of investigational rigor to generate this evidence. It was all FDA pivotal approval trials that generated this evidence. There have been, over 9,000 randomized patients in clinical trials in the United States in descending order of risk that has clearly demonstrated the benefits. So that's why the adoption's been so wide and so broad, because the evidence is so strong. Plus, it's a easily teachable procedure. The industrial sponsors have done a phenomenal job of training, and the devices have iterated and gotten easier and easier that even a surgeon can do it.
And at ACC 2022, there's latest data was presented that showed that in some cases TAVR may actually have better outcomes in terms of durability than surgery.
Yeah, I think the answer's clearly out on durability. I have no idea what the answer is. We tell patients that our best estimate is that surgical valves last 10 to 12 years. Right now, there does not seem to be a signal of a concerning signal in TAVR at all. But there's only a few patients that are out to 8 years right now, because the early patients were all high-risk patients that had decreased life expectancy. So I think there's a lot of surgical valves over the years that look great out to 8 years, and then they kind of fell off. So I think there's no reason to be concerned that the durability is less. I find it hard to believe that the durability is going to get better, but there's nothing to do other than wait. And I think, we'll see. That's why in the low-risk trials, we have 10-year follow-up planned in all of those patients to answer specifically that question.
And there's a lot of concern, I think, early on with the TAVR valves that this is going to be something that's only for really sick patients, high risk. They're not going to go to surgery, so this is their alternative. And then it was shown that it works just as well in moderate risk patients or low risk patients. And then the durability is like, well, this is a valve that you crunch down, stick into a catheter, right. You have to expand it. So it's probably not going to last as long, but there doesn't seem to be any evidence of that.
So far not, and I was one of those that felt that the durability was going to be less because you did crimp it to put it in. The leaflets are thinner than they are with surgical valves, so I thought it was going to be less, but so far that is not the case. But we're still early on in that. But what I would also say is, let's just say hypothetically that surgical valves last 12 years and TAVR valves last 10 years. All right, let's just say we know that as a fact. I don't think that's going to make a difference in the grand scheme of things. I think the key is figuring out the lifetime management of a patient with valvular heart disease. And if you're 80 years old, you're going to only need one procedure just because of your life expectancy. But when you get down into your early 60s, you're going to need 2 and you're going to need 3 procedures. By the time you get to 3 procedures, one of those is going to be surgery. You can't get the Russian doll effect of TAVR and TAVR and TAVR. So one of them is going to be surgery, and what the decision is going to be is which order surgery comes. Is it first or second? You don't want it to be third, of doing a TAVR explant in somebody that's in their 80s in a complex operation, but I'm afraid that's where we may be going to.
And what is the TAVR volume right now? I believe in 2019 we surpassed 50% for aortic valves.
Yeah, so in 2021 there are 92,000 TAVR valves implanted in the United States. Yeah. And if you look at the lines crossed in 2018 from isolated surgical aortic valve replacements in TAVR, now it exceeds all types of aortic valve replacement. And if you look at the proportion of all patients right now that undergo isolated aortic valve replacement, it's about 84% TAVR, 16% SAVR.
Wow. And the big concerns, I think, early on, especially when you had that competition between the interventionalists and the surgeons 10, 15 years ago, the heart team approaches really kind of seemed to bring those two sides together and work in a collaborative relationship.
Well, I would say as much of a game changer as TAVR has been, I think the heart team concept may be even a bigger legacy that's happened out of all this. I don't know who named the partner trial, but they were prophetic in a way. I mean, it's such a great name because that is the way how things have developed. And there's been a coattail effect to all aspects of cardiac care, from mitral valve disease now to coronary disease, et cetera. So it's a huge coattail effect legacy that's happened because of TAVR that arguably in the long run may be even greater than TAVR.
And in terms of the surgeons, with their surgical volume possibly being taken away, how does that work? Is it that there's more patients getting replacements than there would have been under surgery alone, and what are they left with? Well,
so a couple things. One is, as I said to begin with, we thought we operated on everybody with aortic stenosis, and we didn't realize as surgeons that there were patients that were screened out and never referred because their primary care cardiologist or physician, didn't feel the patient could survive surgery. So it's opened up treatment to a whole group of patients that previously, couldn't undergo surgery. Second is there's still a great sense that it's an underdiagnosed access to care issue, and there still are, a 2 or 3 or 4 times greater number of patients that are not being treated that have severe aortic stenosis. So there's a lot of efforts going on to identify that. The other aspect of it is the history of thoracic surgery is staying one operation ahead of extinction. So I'm not worried about the future of cardiac surgery by any means. It started out as a specialty that treated tuberculosis, and then antibiotics came in, and then rheumatic heart disease, and penicillin came in, and then coronary bypass, and then PCI came in. So defibrillators, pacemakers all started in surgery. Bronchoscopy started in surgery. And as they iterate, they become less invasive. You don't need a surgeon to do these anymore. It's going to be the same thing here. The next big future is advanced heart failure, left ventricular assist devices, that type of thing. So, and still, coronary bypass is still the most common operation done in the United States. 65% of all cardiac surgical procedures are CABGs.
And how about the surgical volume overall? Has it actually declined, or is it actually remain the same because now you're bringing in a larger pool of patients?
Yeah, no, the surgical volumes have not declined. They're actually beginning to tick up again, as well as the number of applicants to cardiac surgery residency programs are ticking up again. 10 years ago, it was felt to be a dying specialty, and the best and the brightest were not interested in going into cardiac surgery. That's totally changed again. And now there's more applicants than there are positions available.
And where do you think TAVR will be going in the next few years? You have this branching out now into the mitral space, into the tricuspid space.
So, a couple things. I think, the efforts in TAVR itself right now are to look at upstream diagnosis and treatment. So should asymptomatic patients be treated? Should patients with moderate aortic stenosis be treated? And what can we do to detect patients earlier? As I mentioned, we don't know the true prevalence of the disease. So I think that's the area where TAVR's going. I've shown a slide in a presentation over the years that right now TAVR looks like a straight highway, mitral look like a cloverleaf interchange, and then tricuspid, a multiple interchange. I think that's flipping. I think mitral is going to remain the most complex, and tricuspid is going to be the next area that's going to explode, because there's 3 devices that are close to approval, anticipated to get approval next year. Plus, there is no good treatment for tricuspid valve disease, so there's a huge clinical unmet need. So I think we're going to see tricuspid kind of inch ahead of mitral in terms of it. On the other hand, I wouldn't expect lightning to strike twice. There's not going to be a TAVR deja vu because it was a single disease that's treated by a single method, and mitral and tricuspid aren't that way.
You're also talking about more complex anatomy and a little bit harder to get to.
Yep, yeah, and multiple etiologies of the disease.
Right. Well, I appreciate your time.
Absolutely, thank you.